Okay.
Thank you.
That is the endoscopic hanger, sir. Patient chair. Here, voice therapy. There will be another patient chair here. Voice therapy. So I have the laryngeal stimulator and the keyboard MIDI player here. Hello, laryngeal stimulator, vital stim on. Hello. Hello. For the notes, yeah, for the pitch. Here the MIDI player is there. Downstairs there's a keyboard for the pitch. So, please come in. Madam. They are my undergraduate professors, my first year professor, second year professor, third year professor. I didn't come to college, so I won't know. Sir, 1 minute, the scope alone is coming. It's downstairs.
லைவ்ல தான் இருக்குல்ல
Patient is free company, nobody else.
Permanent patient for it.
Sir, every scope, I tried Pentax, I tried stores, flexible stores, rigid, Pentax, different kinds of scope, everything on him I tried, sir.
At least some context.
Yeah. All, because I needed one single patient to try out everything, no? Then only I can find the difference which is better. Sir. Sir, please leave him on that.
அந்த பக்கம் போயிடலாமா?
Yeah.
சரி.
Yes.
எனக்கு ஒயிட் வரல. லைட்டாக பேக்கில். ஒரு நிமிஷம் பேக்
Sorry.
Very comfortable.
Very soft,
much,
very
comfortable.
sleek.
Yeah. Sir, if you want to switch it on.
Switch it for you.
Already on like that? Actually, I've started using it, but technically. Pinadi on the that. You just switch it on.
This one.
கொஞ்சம் லைட்டாக பேக்கில்.
It's like. This also is connected to so the patient can see what they are. Yeah. So when the patient is here, if they want, they can see for the if they want, they can see. Yes.
So that they want to therapy.
Even for therapy, for their closed throat, they want to open up, they can see what is happening. Feedback will be there.
So they say, should be correct. Our training is there only. Saving everything planned over.
Sir, he is asking for another 35 lakhs for me to archive. Already he's taken 2 kidneys and liver. I can't give him more. So another 35-40 lakhs or something for that archiving system. And I will take a pen drive.
They give you the three.
That is the only thing I survive.
If you not with this much diagnostic, then later you can. It's supposed to grow more. It should, yes. I really appreciate more, but I'm the one who is in South India. They said that madam was not interested in any
But the name change is very half a
gynecologist. Come forward to this secretary. She's one of the reserved.
Definitely, you notice more also.
Yes, quite for a nonsense.
The confidence in the
He already understands.
patient இருக்காங்க ஸ்ரீகாந்த் சார் if you want to get to us okay வேண்டாம் he was very already உள்ள வாங்க யாரும் உள்ள வாங்க ஒரு நிமிஷம் I just call people inside
Yeah, go through the nose, go through the Yeah.
எனக்கும் ஒயிட் ஆகும் சார் ஓகே வரலாம் ஓகே
Okay, thank you. Like, hand it to your. Yeah, yeah.
அப்படி எடுத்துகிட்டே வந்துடுறேன் சார் ஒரு நிமிஷம் இந்த பக்கம் வந்துருங்க, இந்த பக்கம் வந்துருங்க.
He's my team.
We also have Dr. Ilse Janizo Group. He's a director of oncology like to now have the lighting of the Kuttu Velakku. I would like to call Dr. Jayakumar Menon sir, Shri Unikrishnan sir, KKR sir. Fan off பண்ணுங்க.
Very good people. Thank you. Thank you.
I don't know what I was talking about. Malayali and Tamil together is very difficult. Take care, sir. I call upon Dr. Krishnamurthy sir to honor Dr. Jayakumar sir, who is the chief guest today.
What should I do?
Sir, Ponnada Kota. Ponnada Kota. Sir, sir. I would like to request Dr. Jayakumar sir to address the gathering.
Good evening, everybody. Chennai is hot, Trivandrum is hotter, so travel was not very great. But I am so happy and cool to be here because this is really a joyous occasion. Raghavi is one of my students, one of my favorite students, I will say that. And it's very happy to hear that, that she is starting a laryngology unit here. The laryngology is one area where not many people are there. So there are lots of patients, but number of caregivers are not very great. So that's a welcome change. Somebody is actually coming here, developing a specialty that is really great. And I should also tell that, she will be getting good support from a lot of people here. KK Ramalingam sir, he was my DNB examiner. From the day he knew me, he has been very kind and always encouraging me, always supporting me. I'm very thankful to you, sir. And I hear that you have been giving the same patronage to Raghavi also. Please continue, sir. It is very great of you to do that sort of thing. Krishnamurthy sir has been my teacher from the very beginning. There is a saying that an ordinary teacher tells things, a good teacher explains things, a fine teacher demonstrates, but a truly great teacher inspires. If that definition is correct, then I think I have found my inspirational teacher. He has been the person who actually inspired to take up anything new. So, and again, Raghavi, I always tell Raghavi that whenever you got a problem, you contact us, sir. He will be always giving some kind of advice. So she's very lucky that there are doyens of END here to support her. That's really great, and she has got her own support here. Like Vishnu is a very quiet supporter. He is too busy. He is so brainy a person, no, into the chess grandmaster. And I think many of you might be knowing that the Gugesh, who is actually going for the candidates, his watch. So that is great. All of us are here to support, and I think I also should tell something about Pentax and Prem. I have been knowing Pentax, and they have got very super scope and also super expense also. but that is understandable. That is great. But I should tell a few words about Prem. No, it's not about the Pentax thing. Prem has been a great support. Whenever there is a problem, that is a great thing about Prem. He always support you. It is not just buying the scope. So I think you are actually in good hands as far as the instrument is concerned. So Prem, thank you for that, supporting Raghavi. So let us continue with the CME, but all the best for Raghavi. Thank you.
I now request Dr. KKR sir to honor our next guest of honor, Shri Unikrishnan sir. I now request Shri Unikrishnan sir to share a few words with us.
Good afternoon, friends. It's really a pleasure to be here today. I wish Raghavi the very best in all her endeavors. Actually, this is a great boon. I think what you have done is amazing, because as as professional voice users, as a musician, so many times, when we have some problem with our voice, we don't know what's happening inside. So unlike many, if you're a sportsman, you know what's கால் உடஞ்சா தெரியும், இல்லை ஏதாவது ஒரு ஸ்ப்ரெயின் இருந்தால் தெரியும், அது ஈஸியாக கண்டுபிடிச்சிடலாம். ஆனால் நம்மளுக்கே பார்த்தா தெரிஞ்சிடும். ஆனால் வாய்ஸுங்கிறது உள்ளே எங்கேயோ இருக்குது. அது என்ன ஆகுறது, what is happening there, it's so difficult to even identify. So we are like கண்ணை கட்டி காட்டில் விட்ட மாதிரி தான் அந்த ஒரு. ஸோ இந்த மாதிரி ஒரு எக்யூப்மெண்ட் இருக்கிறது it's a huge boon for people, professional voice users, to at least know what's happening there, how we can rectify it, if there is some muscle problem there. So it's so useful. So I must really thank you for bringing this thing, and the company, what is the Pentax, right? And Pentax is, their doyens, the pioneers in the cameras and lenses. So I think the quality is also so fabulous, like what doctor mentioned. So, and I also experienced this. I was with her last 2 weeks back, and checked my voice, and it's so comprehensive, so beautifully it gives the right diagnosis. So really thank you for this, and wishing you all the best, and I hope a lot of people benefit from this thing. Take care.
Thank you. Thank you, sir. So before we move on to the CME, Dr. Raghavi will share a few words with us.
Ah.
Thank you all for coming here. I don't know what to say, but when I did after my PG in MMC, I thought I'd studied quite a lot, and then I attended a half-a-day workshop with Dr. Jayakumar Menon, and not even one word that he told I knew. So I decided I was going to follow him all the way to Trivandrum, and the laryngology journey started over there, and it's great that it's progressing, and to have a mentor like him, like Manju madam, who have been not just supportive during the course, even after that, doesn't matter the time, doesn't matter the day. Today is Vishu. Still, when I told him, he was like, oh, it's Vishu. And the second moment, he was like, okay, I'll come down. So when both of them, they don't mind the day or the time, and they still keep supporting not just me, any of their students, any of them. So it's so great to have such mentors that really helps us to take a step forward. When I was even thinking about Pentax, which was last year this time, I just bought the HugeMed scope, and that was a big thing for me. And to invest 10 times that and to go ahead for Pentax is a very great step for me, and that wouldn't be possible without the support of my mentors and the doctors in Chennai, and also my patients who have trust on me as well. So it's been great. I really have to thank Mr. Krishnan also for coming here in a moment's notice. All this, the whole arrangement has happened in less than 2 weeks, and it's so great to see all of you here. Dr. KKR sir, Dr. Krishnamurthy sir, I'm really very happy. I'm actually out of words to thank you all. My professors, my teachers are also here. It's so great to present all this in front of you. And one, as sir said, Prem has been a real big support. He was here till 10:30 last night getting the renovations done and following it through. It was not just his instrument that he did, but even the interiors he helped me do it. So it's really been a great process, and I really have my friends who are like family. I'm so happy and I'm really emotional. All of them here, they've been the backbone of this program, including my husband and kids, but it's all these people who are here arranging it. Thank you.
சீன் ஸ்டார்ட் பண்ணிடலாமா ஐயோ நான் இது ப்ரோக்ராமே கொடுக்கல. Can you get the...
Yeah, we'll start the CME. We'll start the CME now because the other people are waiting online.
Yeah.
topic will be unilateral vocal cord paresis. So there are 4 speakers. Dr. Manju Isaac is my teacher, and I mean all these things, several places it's available, but there are a few things that I would like to tell about her. When she's been a teacher, it's not just teaching from the subject or from the book or something like that. She understands where we are going wrong while doing a surgery, or where we are making a mistake, we are missing things. She tries to comprehend that and corrects it. So that is something that it's so difficult. She understands, articulates where we are going wrong, and she corrects it. And not just with regards to laryngology, even life lessons, a lot of it she's given. She's more of a family than just a teacher. So yes, madam, we'll continue with your talk. Thank you so much for coming.
Good afternoon, all. At the outset, I would like to congratulate Dr. Raghavi on her wonderful achievement, and I'm so happy to be part of it. And my topic is recent concepts in the diagnosis of unilateral vocal fold palsy. Okay? Yeah. Okay, all right. So, when we talk about vocal fold palsy, we need to understand that, we need to remember that there is some kind of a residual activity or synkinetic activity that is going on in the vocal fold. So, there is no, the complete palsy is not the usual case. And of course, we see occasionally obvious paresis with some motion in the vocal fold. The causes generally it follows surgery or trauma. Then there are the compromise with the part of a lot of medical conditions and surgeries and idiopathic cases. So, the evaluation part involves thorough history taking and physical examination. So, in the history, when you take the history, you should think about all the etiologic possibilities and take the history, like whether the patient had a surgical procedure, whether the patient had a trauma in the part of neck, head and neck, and whether the patient palsy happened following upper respiratory or lower respiratory infection, which suggests that it could be a neuropathy. Then endotracheal intubation has been implicated as a cause for vocal fold palsy, of course stroke, and neurotoxic medicines like vincristine, vinblastine, and occasionally cisplatin. And the symptoms are due to glottic insufficiency resulting from some degree of lateral placement of the paralyzed vocal fold. So, the main symptom is hoarseness or dysphonia, and it can range from a mild vocal fatigue in a well compensated case to complete aphonia in a severe case. And of course, patient will be having this swallowing problems also in especially when the level is high vagal or a brainstem. And the quality of the voice, how you assess? So that depends upon the muscular tone of the paralyzed vocal fold and the compensatory strategy that the patient try to make it while phonating. So, atrophic, weak, not well compensated paralyzed vocal fold will have a voice which is breathy and weak. And there will be a wet quality to the voice when there is a high vagal lesion because of the retained secretion in the pyriform sinus. And patient will progress to a more stronger voice with a lot of compensatory strategies, and supraglottic phenomena are like that. So it results in rough, pitch locked, low frequency voice, especially when there is anteroposterior squeezing of the larynx, like between the adenoid and epiglottis, as well as ventricular band adduction. And some patient will have an unusually high pitched voice. So it is referred to as paralytic falsetto. When there is a high frequency, when the patient speak in a high pitched voice, like there is an increase in the fundamental frequency of about 85 hertz above the natural pitch. And occasionally, when in high vagal palsy, patient will have swallowing problems like cough on taking liquids, that is immediate cough. So there is laryngeal incompetence, and some patients will have weak ineffective cough also. So this patient audio. So you can see that patient is having very breathy, weak voice. And what happens when he takes the liquid? Immediate cough. And this is, see, it's a high pitched voice. So it is paralytic falsetto. And examination of the neck should include looking for adenopathy, thyroid mass, palatal movement, and all the other cranial nerve examination, and maximum phonation duration. So that will be reduced in vocal fold palsy up to less than 10 seconds. And in severe cases, uncompensated cases, less than, it can become less than 5 seconds. So here he cannot prolong the phonation beyond that. And the best way to assess the vocal fold movement in its natural state is to do a fiber optic laryngoscopy. So when you ask the patient to protrude the tongue, and when you grasp it with a gauze, so it affects the biomechanical or a normal physiological mechanism, and what happens is it will interfere with the natural vocal fold movement. So you will not be getting a natural picture. So and one more thing is very important is that it should have you should look for prolonged a period where you have to give certain task. One such task is e-sniff maneuver. So in this patient, phonate E like that, and in between the patient has to sniff vigorously. So it will give a good view of the actual mobility of the vocal fold, alternating E and sniffing. And there will be some supraglottic phenomenon like ventricular band adduction. So you won't be seeing the vocal fold. So it become very difficult to see where is the which chord is affected to. So in those cases, Kaufman has advocated the unloading phenomenon. So that is how you do is you can hum like that, and then sigh and phonate. Like that. So it will unload the supraglottic phenomenon, and you can see the vocal fold very well. And another thing is we ask the patient to turn the head to right or left. So, and see, generally we see that when in case of paresis, the voice improves when the patient turns the head to the same side, affected side, and in palsy to the opposite side. And stroboscopy, how it helps? It is helpful in finding out paresis. There will be subtle paresis like that. It is difficult to understand, but the patient will be having complaints of hoarseness. So you can see that there is incomplete closure, as well as the on the affected side, it is increased amplitude of waves. So you can see mucosal waves. So in the side that is affected, you can see increased amplitude of the waves. Like on left side, you can see here. So, there are other causes for vocal fold immobility other than neurologic causes. So, when the joint is cricoid joint is affected, it can affect the vocal fold mobility. So, how you find out? So, there comes the role of EMG, as well as you can palpate the joint, cricoid joint under general anesthesia. And another investigation is to find out what is the cause that is causing this vocal fold palsy, that you can take CT net from skull base to mid chest. And next is you need to see which muscle is affected. So how it is helping? It will help in taking a correct treatment for the patient, because according to these muscle groups, the treatment also changes. So for the convenience, I have divided this into 3 groups: the anterior adductors, mid-zone adductors, and posterior adductors. So coming to the anterior adductor, that is thyroadenoid. Thyroadenoid is the true adductor, a true anterior adductor of the vocal fold. So what are the actions? It actually thickens, give the bulk, give the tone, and closes the anterior 2/3 of the vocal fold. I hope you could appreciate that from this video. Now, this is a case of left vocal fold palsy, but you can see that the gap is in the anterior. Otherwise, it is like it looks like a well compensated thing. So there is a gap in the anterior part only. In this case, again the gap is in the anterior part, but you can see that the vocal fold is bowed and atrophic, right? So coming to the mid-zone adductor is lateral cricoid. So it closes off the vocal fold at the level of the vocal process. All right, let us see the video first. So the closure is at the vocal process level. Let us see a case. We can see that there is a bigger gap at the level of the vocal process level. That is about lateral cricoid. Then the posterior adductors, that is the interarytenoid. So the interarytenoid, it's a unique muscle in that it has got a transverse belly and oblique belly, and the transverse belly has got a bilateral innervation. So it closes off the vocal fold at the posterior most part. That is, it brings the arytenoid, body of the arytenoid together. So lateral cricoid node was at the level of the vocal process of the arytenoid. This brings the body of the arytenoid together. And here in this video, you can see that there is a gap at the posterior most part, and you can very well see the paralyzed vocal fold in its entire length. Usually that much is not visible. It can abduct, but adduction is not possible. And the superior laryngeal nerve. So the EVSL supplies cricothyroid muscle. So when the cricothyroid muscle is affected, there will be reduction. The patient cannot raise their pitch, right? And it stretches the cricothyroid, stretches the vocal fold and gives the vocal fold tension. So when it is affected, see the finding, the vocal fold is flabby on left side. Isolated superior laryngeal nerve palsy is very rare. And there are so many signs actually described, but none of them are actually convincing. EMG is the ultimate diagnostic modality in diagnosing the superior laryngeal nerve palsy. But what finding is there that the usual membranous to cartilaginous vocal cord ratio is 3:2. So here what happens is it becomes 1:1. So in this picture we can see that right side is normal 3:2, but here the membranous to cartilaginous ratio has become 1:1. Okay. Now the posterior cricoid node being the only laryngeal abductor. What is the role of posterior cricoid node in phonation? Posterior cricoid node muscle actually holds the arytenoid onto the cricoid against the pull of other adductors. So when it is paralyzed, what happens is the arytenoid actually prolapses anteriorly and medially, like you see in this video. On the left side you can see that it has prolapsed anteromedially, and you can very well see the posterolateral surface of the arytenoid on that affected side. So I hope you can appreciate that this is involvement of the posterior cricoid node muscle and not arytenoid distribution or subluxation. It's not a joint problem. And finally, have you ever wondered that when a patient comes to you with the other complaints, patient doesn't have hoarseness, but on video laryngoscopy you are finding out that the one of the vocal fold is not moving, but in a more medial position, in an adducted position. But patient doesn't have a complaint. And in another situation where patient had a vocal fold palsy, the patient had hoarseness, but that hoarseness improved on time. But on video laryngoscopy, you are seeing that that is in a more medial position, that is in an adducted position, well compensated position. So have you ever thought about that? So this is nothing but that is because of synkinesis. So we all know that what is synkinesis, right? So there is misdirection of the regenerating nerve fibers to the wrong muscles. That is, the abductor muscle will get adductor fibers, the adductor will get the abductor fibers. And we know that in the larynx, 75% of the nerve fibers are for adductors and only 25% are for abductors. So in synkinesis, there is a misdirection of these fibers. So the adductor muscle, when it get more of a adductor fibers alone, it is called adductor synkinesis, which is good in a case of unilateral vocal fold palsy. Roger Crumley has actually did a lot of study on synkinesis, and he has found out 4 types of synkinesis, of which 2 are important in unilateral vocal fold palsy. So that is adductor synkinesis, and the other one is abductor synkinesis. So in abductor synkinesis, what happens is the fibers that are destined for the adductors that go into the abductor muscle, that is the posterior cricoid nerve. So the vocal fold will be in the more lateral position. So that is the reason for this position of the paralyzed vocal fold. So actually the synkinesis has a major role in determining the final position of the paralyzed vocal fold. So a patient with the adductor synkinesis will have good voice, but a patient with the abductor synkinesis won't be having, they have a breathy, weak voice. So neurolaryngology is actually growing up very fast, breathtaking pace, and we hope that most of our problems will have a solution in the recent near future. And with that, that was about the recent concepts in unilateral vocal fold palsy diagnosis. And thank you for your patient listening.
Just one moment. Never put it for anyone. This is the first time I'm putting. It's so much clarity. So we'll be Dr. Ilter unmute பண்ணணும். Dr. Ilter unmute பண்ணணும். So we'll be going to the next topic. We are running a little late because they have to catch their flights. We'll go to the next topic immediately. Dr. Ilter Denizoglu is from Turkey, is going to be giving the next talk. So the first time I heard about him was from Jayakumar sir about the lax walks and everything. But then listening to his concepts, I went all the way to Izmir and I understood how passionate he is about the subject and to what depths he goes to understand about the vocal cord and the physics behind the vocal cord, which helped him devise the Dr. Vox therapy. Hopefully, we will bring it to India as well. So we'll go ahead with his talk right now. Yeah, you're online right now. Unmute பண்ணியாச்சா? Sound வருதா? 1 minute. இது இல்ல unmute doing unmute.
Hello, do you hear me?
Yes, we can hear you, but we just need the sound to be a little more louder.
Do you hear me? Hello.
Yes, 1 minute. இங்க unmute தானே?
Hello.
Can you hear me?
I can hear you, but do you hear me?
Yes, we need the sound to be a little louder.
Yeah. Now I have to stop the YouTube voice, YouTube sound. I think.
No, now it's okay.
I hope you hear me now.
கேக்குதா? Can you speak?
Is it okay?
No sound. இதுல sound.
I stopped it. I stopped the YouTube. Maybe I will stop the whole YouTube. Wait.
Yeah.
Now, do you hear me better? Yeah?
Yes, yes.
Yes, I think so. I would first.
Thank you.
First of all, I would like to thank you for this kind invitation. It's my great honor and pleasure to be with you and my dear friends in India. Now,
Yes.
you see this slide? Lateral vocal cord paralysis, voice therapy, and injection laryngoplasty. Conflict of interest. As we know, the larynx has a very complicated, complex innervation because it is an organ that combines three most important survival functions of the body: breathing, swallowing, and formation. Possibly, this is why there are narrow anastomosis between right and left larynx, not like in any organ. And this is why we can call, instead of paralysis, synkinesis, because a real silence, real electrical silence in a vocal cord muscle, it's not so easy. In the leg, it's possible, because if you cut the leg nerve, whatever the name it is, but it is possible. But in the larynx, it's a little bit different. That's because there are, let's say, we have 10 different patients. All of them come to us with different voice problems after the same operation. Let's say thyroidectomy. Some come to us, this is my voice, but I cannot shout. Some come to us with, well, this is not my voice, and I can not speak that much. Some say, oh, it's a real hoarseness for me, it's diplophonic, or completely, I cannot communicate. And there are some, reposition theories, but when we put all of them to one side, does not necessarily predict the site of lesion because of the complicated innervation. And it's mainly caused by the degree of reinnervation and synkinesis at the same time. That can be, if there's the unilateral vocal paralysis, it can be median, paramedian, intermediate, gently abducted, and fully abducted. So, voice after unilateral vocal cord paralysis can be breathy, of course, and there are some registered rates when they paralysis. And there is an habitual fundamental frequency increase because the superior laryngeal nerve is not affected, and the bilateral CT muscles still can pull the vocal cord and the falsetto register. Is everything okay?
Yes, there was a echo.
I mean, I just closed everything. It's only one microphone from my side.
எல்லாம் இங்க ஓகே தான். Yeah, now it's clear. It's okay.
It's okay.
Yeah,
okay. And because both vocal cord biomechanics has been changed, diplophonia is a problem. And maximum phonation time is less, and the cough, as the doctor told before, is not good. Also, aspiration of liquids. So, clinical manifestations define our treatment action plan. Unilateral vocal cord paralysis. What are the treatment modalities? Voice therapy, surgery, medical treatment, and I'm going to speak about voice therapy in the first row. The rationale, the voice therapy, because it's always asked. So there's a paralysis. Why do you make voice therapy? Because the structural reorganization should be under our control, which is like form follows function. We must not let the muscle atrophy, if possible, the joint fixation, CAJ. The compensatory glottic rotation is also a laryngeal behavior after vocal cord paralysis. And if possible, it's a question mark, maybe we can redirect neural regeneration by giving some exercises to our patients. When do we start voice therapy? As soon as possible. I always say to my patients and to general surgeons who make the thyroid surgery, as soon as possible. And of course, monitoring needs and demands of the patient is important. The patient is an active teacher, and I'm going to show one patient like this. She wants to go on with the business because she's an active teacher, but the manager of the school wants her to be retired because of the voice problem and aspiration and dyspnea. These are all serious problems for the voice therapy. So, factory settings of the larynx is changed. And we cannot reset this like we do in singing voice therapy. We cannot restore it because the neural input is different. So, but we can create new settings. Our motto is form follows function. What are the main principles of voice therapy in unilateral vocal fold paralysis? First of all, the problem in unilateral vocal fold paralysis is chest register is disappearing. And possibly the falsetto register, which means we use only one upper third of the upper one third of the glottis by the pulling of the both CT muscles to increase the glottic resistance. And what do we do now? We use some back pressure to increase the glottic resistance from the lower two-thirds of the glottis. And breath management is important because patients tend to take the breath management to the upper body in order to try hard reflexively. And it's also a problem for us. And provide a new motor skill, vocal motor skill, a new behavior, because now it's not the original instrument, but with the new instrument, we can go on our communication protocols almost with no problem. I would like to speak about our protocol, Dr. Vox voice therapy technique, which is a multi-level, multi-dimensional treatment strategy with 3 dimensions and 4 levels. The first dimension is action plan. This is our clinical way of thinking, step by step. So action plan is what we are going to do. Reset, explore, development, adapt. So we are going to prepare the patient for the vocal exercise. If possible, we are going to find a sound that we need to hear, and then step by step develop that sound by developing the muscles consciously with muscle-specific exercises, and then with the new setup, we adapt the new behavior to daily life. The second dimension is the exercise. So each and every level, we have some well-defined exercises, and like we have in the surgery room, the tools, the surgical tools we have, and these exercises are like toolbox. We have 50 surgical devices, surgical instruments to one surgery, but we only choose let's say 17 of them in that case, or in another case we can choose 25 of them. So it's a toolbox and there's no stabilized schedule. The third dimension is monitorization, because our patient is a biopsychosocial being, and we must monitorize, we must be aware of the motor learning protocols. Here we use it as a monitorization protocol in our patients. So cognitive, associative, autonomous, and I think Dr. Spaya will speak about this in a deeper context. So what do we do to prepare our patients? First of all, we create a balanced posture. Breathing and apogeo, I mean, we take the breathing effort from upper body to the lower body to prevent the trying hard reflex, like position, to take this from the reflexive behaviors of the larynx, because then the people who use this reflex in some months, if not years, they try to speak like that. So we don't want this. And the relaxation, again, not slouch, not fixed, but just be ready. And posture here is our first thing. The prince or princess posture helps us a lot with high sternum, relaxed shoulders, and active spine with a balanced head, because they try hard using the upper body. The second thing is find the chest register. Well, or if the glottal gap is too high, and if you cannot understand, you cannot hear the chest register, you can start from the falsetto. Because we have two muscles, if we have, of course, if it's not, if the surgery did not go to the superior laryngeal nerve, of course, but we can use the falsetto, and after increasing the CT muscle power, then we can come to the chest, like this, with probing maneuvers, or just try the high back pressure. And if you increase the back pressure, semi-occluded vocal tract, as you know we use, if the chest sound comes with a reasonable resistance with sostenuto, then we change it, increase the level of the pitch range, and then we glide upper chest registers, and the autokinetic exercise with it, and increase it, increase it, So here, we try the high back pressure to keep the glottic closure better by changing the muscle power. So the level 3 for the DVT is develop the glottic closure muscles after finding a sound that comes from the chest register. Here you can increase 15 to 25 centimeter water and as possible as the lower pitch, because we also want the TA lateralis to be activated. Again, you can use falsetto register by isometric contraction assisted by TA with high back pressure. Glissando is always used as an isotonic contraction to balance the TA and CT. So our aim is the TA. So by using the CT's symmetrization activity, we can try for the TA by gliding to the low pitch as lower as possible and proceed with it gradually. Staccato, as mentioned earlier, is a good thing to activate the interarytenoid muscle. The interarytenoid muscle is a good muscle because it's innervated bilaterally, plus it has fast twitching fibers inside, so it's the first muscle that will respond to fast motor tasks like So staccato is also can be used for voice therapy protocols, and then we combine the exercises to make it more difficult, and first high and low exercises, then we blend the staccato and then so now we are blending interarytenoid plus the TA vocalis, medialis, and the CT muscle together, plus the LCA here also, in a complex task to go on with linguistic law. Now we can add language into what we have provided to our patient. Then we use the mask, the oral mask, to add speech and for singing, and this is the adaptation protocol for behavior transfer. And then we get everything out and go for the conversational speech and singing in the daily life. So I would like to show some cases. She's a hotel manager with the right vocal fold paralysis, and her voice is like. You can see the folding.
Mesleğiniz otelcilik. Şikayetiniz nedir? Sesim kısık. Bir daha ona kadar dayanır.
Can you hear the sound of the patient? Hello?
Yes, yes, we can hear.
Sound of the patient also. Okay, thank you.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Uzun bir A.
It takes some months, especially in the paralysis. You can see the capillary closure. Oops, sorry, sir. İlerle.
Kaç yaşındasınız? 38. Ne iş yapıyorsunuz? Otelciyim.
The next one
Peki,
is
ona kadar.
architects, also vocal paralysis. This time, the vocal gap is a little bit more prominent. And you can see the comma sign.
1, 2, 3, 4, 5,
And
6.
after the voice therapy,
Üç, 4, 5, 6, 7, 8, 9, 10.
so another one, this is a lymphoma case. Look, the also the actual
2, 3, 4, 5, 6, 7, 8, 9, 10.
and this is after.
Kaç yaşındasınız? 22 yaşındayım.
Ona kadar sayın.
1,
So let's
2,
go to
3.
the other section about the injection medialization to keep my time properly. So what are we going to make in unilateral vocal fold paralysis? We can think in 3 periods. The first period is the early intervention period. It's like the first 3 months. You can, of course, start the voice therapy in the first week. Exactly. And electrotherapy may also be used, which can also be efficient for an assistance to voice therapy. Here, we can make a temporary injection laryngoplasty as an office procedure to save some time for the patient. Because immediately after injection, the patient starts speaking, and our voice therapy protocols are really easier than if you do not make the laryngoplasty. And I prefer hyaluronic acid in these cases. Sometimes, if there is a well-known injury about the patients' recurrent laryngeal nerve, like the thyroid cancer, and no hope is there for recovery, then we can make a permanent injection laryngoplasty in this early period. The intermediate intervention is between 3 to 12 months. There's still hope for recovery, but it shows itself after 5th month. Generally, some synkinetic reactions, the resistance, as I showed you, resistance of the affected part is important. If there is a small gap, use voice therapy. It will be efficient, as I showed you in the cases. And if or the gap is not that small, then you can make temporary injection, but saying that we can take you into assessment again 6 months later, and permanent injection can be discussed with the patient. The late intervention is after a year or maybe 9 months. Now, if the voice is still problematic, then before voice therapy, surgical treatment, probably a permanent injection laryngoplasty can be offered to the patient, and then the voice therapy will be added to the patient's treatment strategy. Of course, we must be very careful about the CAJ, like fixation and atrophy and so on. Injection medialization is an easy protocol which can be made in office or under general anesthesia, but ideal injection material is a question. It should be biocompatible and vibration friendly, reversible, and so on. So there are different injection materials, short, intermediate, and long materials. Here, I prefer 2 materials in this list. The first one is the hyaluronic acid for short injection. The second one is the fascia lata for. You can, as you can know, you can imagine, laryngeal injection can be transoral, transcervical, and injection site is important here. There's a tricky thing that I use, not only to the membranous fold, but I use the injection, if I use it permanently, to the posterolateral part of the vocal process, in order to turn the vocal process a little bit to the medial and to the healthy part. Healthy, if there is a big gap, I use also the healthy part injection, and I'm going to show you one injection laryngoplasty in the office. Here you can see left-sided vocal fold paralysis. So you can see the needle here. So needle is in the muscle, and you can see the injection is okay, and the vocal vibration is there. And the second is with the fascia lata injection. So this is
Sınıf öğretmeniyim. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So, for the fascia lata injection, we take the fascia lata. You know, we are ENT doctors, laryngologists, so it comes to us a little bit take something from the leg, but if you work with a plastic surgeon, now it's better, I think. If you work with a plastic surgeon, they will show you very efficiently how to take a fascia from the leg muscles. And here we take the fascia first, and then after taking it, first we cut the fascia from the by taking it on the lamel, we cut it perpendicular to the fibers. This is important because after mincing, some fibers can obstruct the needle. So this is what we do, a small trick, perpendicularly cutting the fascia. And then, after cutting it with the help of the assistant, then we start mincing. Mincing is done like this. We are preparing the fascia for injection. I modulated it by washing with a PRP also. This is the autolog PRP that increases the viability in my opinion. And after mincing, we take the injectors, we take it into the injectors. I am making it a little bit quicker. So we just fill the injector with the fascia lata. And now you can see the injection site that I use. So I first palpate what kind of atrophy is there. And then the other side. The other side is perfect, it seems. And here I need to make an assessment. So as you can see, here there is the vocal process. The needle goes there. And you can see how it gets filled from starting from the posterior part. And you can see the vocal process is also turned to the medial part. And then the next level is to massage on the vocal fold in order to balance the mass effect of the vocal mass to be vibrated. And then we go out, and this is the post-surgical vibration. It has a long-term effect. This is maybe the 4th year of this patient. She's going on teaching, and the voice is...
55.
Ne iş yapıyorsunuz?
Öğretmenim.
Ona kadar sayın.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Uzun bir ağ değil. So this is what I would like to present today. I would like to thank you for your kind invitation again, for this invitation to Dr. Raghavi Vishnu Prasanna, my dear friend and my boss in India, and many greetings, and I would like to celebrate your your World Voice Day in this way, and I'm going to open the YouTube now. If you have any celebrate your your World Voice Day in this way, and I'm going to open the YouTube now. If you have any celebrate your
Can you see me? Jay Kumar here. Shall I start? Raghavi?
Yes, sir, please.
Okay. Good evening, all. So we had the voice, how to diagnose the vocal cord palsy, how to treat with voice therapy, and how to treat with the injection laryngoplasty. Now we are going to the surgical treatment, and this is one area which has seen lot of changes over the last 10-20 years. So we will see. Huh?
Share 1 minute, I'll just share this also.
Oh, right, it has to be there.
Sorry, you can just go online.
So I think everybody must be very familiar with thyroplasty, right? Because actually one of the main reason why laryngology took off is actually because of Ishiki. He described a technique which is so enthralling. Everybody got interested because on the table a patient who was talking like this suddenly became having normal voice, and it was fascinating. And it went on to rule unilateral vocal cord palsy for nearly 40 years. And we thought that was the end. It is not really. Actually, something new has happened now. It is not really, you cannot really call it new. It has been there for a long time. Even before Ishiki, it was there. But that was rather neglected. Now, that segment is coming, neurolaryngology, where you renervate the larynx. And actually, that is threatening. It hasn't happened actually, threatening to totally replace thyroplasty. It is very, very likely to happen in the near future. So, where thyroplasty will become more of a salvage procedure, where you can't correct the voice with the renervation procedure. It's ready now?
Yes, sir.
Okay. So that's what we are going to take. Now, we heard about the temporary case. Now we are talking about the permanent. The vocal cord has been paralyzed and it is not going to recover. Usually the time is taken is around 6 months. Now after 6 months it is not going to recover, even though occasionally you will see somewhere around 8 months. So what are you going to manage? As of now, there are two groups of treatment. One is known as the static treatment, where you close the gap. And you had Manju talking about 3 adductors. The anterior adductor is the thyroid node, the middle adductor is the lateral cricoid node, and the posterior adductor is the interarytenoid node. Depending upon where is the gap, you can actually medialize, you can push it. So if you are medializing the anterior two-third, that is known as that everybody knows, that is the so-called type 1 thyroplasty, or more accurately called the type medialization thyroplasty. If the problem is at the vocal process level, you do what is known as the arytenoid adduction, what is Ishiki called, but correctly descriptively it should be called arytenoid rotation. And very rarely you may get an isolated interarytenoid paralysis, which is very rare because we have seen that interarytenoid get bilateral supply. So that is a very rare thing. But occasionally, less than 1% of cases, you can actually have isolated interarytenoid paralysis, very difficult condition to treat, where you can do the adduction arytenoidopexy. This is a young Ishiki. Everybody knows about Ishiki, but very few people know about this man. Actually, he is the pioneer. He should be actually remembered as similar to Ishiki. This is Jan Wilhelm Vandenberg, the great Danish physiologist who walked well ahead of his time. He lived in 1960s, and he did so many exercises, so many stroboscopic experiments, which actually stimulated Ishiki, younger Ishiki, so when he was watching, he was working with Vandenberg, he got the concept how the vocal cord can be differently positioned by pushing the anterior two-third, rotating the arytenoid, tightening the cricoid. So all this concept of thyroplasty was inculcated in Ishiki's brain by the great Vandenberg, the great Danish physiologist who actually revolutionized. I think people in my age might remember that when we were in DLO, we were taught there are 2 theories of phonation, neurochronaxic theory and aerodynamic theory. It was Vandenberg who put that into rest. He told that there is nothing called neurochronaxic theory. He proved it by creating sound of a dead larynx. He actually took the larynx and trachea, transected the trachea at the lower part, transected the larynx above the level of the vocal cord, put air from the trachea down and push the vocal cord together and then put stroboscope above it. Remember, this was in 1960, man, you are really talking about a genius. And he actually could produce voice, so the cadaver produced voice. So Vandenberg proved that there is nothing called neurochronaxic theory, it is all aerodynamic theory. So credit to Vandenberg. Now there is a new group, that is the dynamic corrections. There are two groups, the non-selective reinnervation, that means you take ansa cervicalis and connect to the distal end of the recurrent laryngeal nerve. Sometimes there is another condition, then it's a paresis, only one muscle is involved, you do what is known as a neurotization or sometimes known as HSR, highly selective reinnervation, where you take ansa and connect to the affected muscle. If it is just thyroid node, take ansa and connect to the thyroid node so that that part gap is closed. So this is essentially the two groups of treatment. And Manju already showed another great man, a person of terrific will, I will say that, because this is Roger Crumley. He has been doing this surgery for more than 40 years. Actually, he was before Ishiki doing this surgery. Imagine somebody is doing, doing his life's work and he is nearing perfection, then some other thing comes. Ishiki comes there, take away all the limelight. Crumley is forgotten. He was doing so many surgery. He was splitting phrenic nerve, he was taking ansa cervicalis, he was taking nerve to thyroid, everything, nothing. Then because this was such a drastic procedure, dramatic procedure. Ishiki's procedure was so dramatic, everybody got impressed. So, Crumley was nearly forgotten. Most people would have been crushed. They would not have survived, that. But not this man. He is now 83, he is still very active. See, just went on fighting that, and right now it is almost, he's back. Now this is the predominant surgery now. So he said his first reinnervation procedure was done more than 45 years back. That patient is still alive, still speaking very well. He always tells in his meetings. But even though Crumley created this, this was popularized by this man. This is Jean-Paul Marie, from whom I learned the technique. He is in France, so he is the man who actually teaches everybody. Now what happened is that another tremendous thing happened. Better understanding of the laryngeal muscle and their nerve supply and ansa cervicalis. If you go into the history of anatomy, especially the later anatomy, the more detailed, intricate anatomy was described by, not by the anatomists, but by the surgeons. I think the classical example will be pterygopalatine fossa. Right? It was not described by the anatomists, it was described by the ENT surgeon. Similarly, now, intralaryngeal dissection of the recurrent laryngeal nerve is gaining. This is our own series. We have done the dissection of a lot of people. So we are seeing lot of things which actually changes the often taught things, right? We were always taught that all muscles of the larynx are supplied by the recurrent laryngeal nerve except cricothyroid, which is supplied by, it is not necessarily low. You see that this is the superior laryngeal nerve coming from the pyriform fossa. The main branch supplies sensation, but there is a motor branch which supplies the interarytenoids, and it supplies ariepiglotticus, and it makes sense because superior laryngeal is the nerve of the fourth arch, and it is above the level of the vocal cords, right? So realistically, above the level of cricoid, and when it is coming, actually they should actually get supply. Interarytenoid many times gets supply from both from the recurrent laryngeal nerve and superior laryngeal. And you can also see that you are now very confident about the intralaryngeal anatomy. Suppose a patient who had thyroidectomy, had vocal cord palsy, come to you, you have to do reinnervation. When you open up the neck, you can't see the trunk. It is probably cut at the entry point. So how to do? So now we will open up the intralaryngeal part. We will dislocate the cricothyroid joint, identify the nerve, and this is a very, very, very predictable position. You identify the posterior cricoid node, you will see the main trunk entering, hugging the lateral border of the posterior cricoid node, then dividing into the thyroid node branch, intrarytenoid branch, all these things. So this is all well known. And like Crumley, ansa was a forgotten nerve. Nobody attached any importance. Head and neck surgeons routinely removed it. But now we know that ansa is not something you can really just take away. They are very, very important. They are our workhorse for reinnervation of the larynx. So you need to know that the answer need to be respected. So you can see that. So two groups of unilateral vocal fold palsy. One, anatomical integrity of the right recurrent laryngeal is not intact. We know that the nerve has been already cut. Say like during thyroidectomy, either you inadvertently cut the nerve or you had to sacrifice because there was tumor involved. Or the second group, you are not very sure. Surgeon is not very sure. The thyroid surgeon says, I didn't dissect the nerve. I don't know whether it is anatomically intact. So then you will have to wait. When the nerve is already cut, you know that you can actually go ahead. No need of 6. And doubtful, not like thyroid surgery, neck surgery and all. Why it is not moving? All right. Okay, sorry. Then it started moving. So, if the anatomical integrity of the RLN is not intact, this is a classical case. You do thyroidectomy, the recurrent laryngeal nerve is cut. Either you cut it inadvertently or you sacrifice it. The tumor was there. What will you do? There was a lot of controversy. You should put injection, you shouldn't do anything, you should give thyroplasty, all these things. But now that is put to rest. We know what we should do. You should take the ansa cervicalis, connect to the distal end of the recurrent laryngeal nerve. So you can see the anastomosis of the recurrent laryngeal nerve. That is Manju's sound. I think she is probably the most experienced person in this surgery in the country now because she has done so many now. Now you can see that she is anastomosing the recurrent laryngeal nerve to the distal end of the ansa is being connected to the recurrent laryngeal nerve, and see the result in 3 months time. You say it's like a thyroplasty. The cut vocal cord has now come to the midline, and listen to the voice. You can see the vocal cord is well medialized. That's a near normal voice. It's like a thyroplasty. Not only that, here you have got a tone. The muscle has a tone now. None of the previous surgery actually increased the tone. Whether it is thyroplasty, whether it is arytenorotation, whether it is adduction arytenodoplexy, it never improved the tone. This is actually changing. So that is what this surgery is known as. So this is the non-selective reinnervation. Now you might ask, why don't you anastomose the curtains of the recurrent laryngeal nerve rather than taking the answer to the recurrent laryngeal nerve? Answer is simple. I think again Manju told that recurrent laryngeal nerve has got 75% fiber firing for adductors and 25% for the abductor. If you again anastomose, it is a mere chance you will get the same thing. Actually what will happen? The fiber will crisscross. Adductor might go to the abductor, abductor might go to the adductor, so that the vocal cord will be fixed in a abducted position, neutral position, the voice won't be good. ANSA fires 10% during adduction. All the fiber actually work during in exhalation. So if you connect answer to the recurrent laryngeal nerve, adductors will invariably get 10% tone, with the result that the vocal cord will be medialized and patient will have excellent voice. And it has got a quoted success rate of 95%. We have done now more than 35. I think we also have got almost same result, more than 90%. They have got terrific results. So that's a very good surgery. Now the second group, where the anatomical integrity of the recurrent is doubt because surgeon didn't know. In that case, we will have to wait for 6 weeks, 6 months, because we don't know whether it has recovered. If it doesn't recover, there are two options. Either you go for the dynamic procedure, that is non-selective reinnervation. A special indication will be children. Obviously, you can't do a thyroplasty in a child, because you need sedation, patient won't lie down. And secondly, more importantly, pediatric larynx is a growing larynx. So if you put an implant now, 5 years down the line, the larynx might have become bigger and the implant might be removed. So that's not really it. And this is the most important thing. Singers. A singer has got a unilateral vocal cord palsy. Whatever static surgery you are going to do, that will not actually make them sing. Their speaking voice will be all right, but high pitch technique, all the muscle tone won't be there. And probably they should be below the age of 70 and non-diabetic. So if these are the conditions, you better go for the non-SR. This was a case who underwent a parathyroid adenoma surgery. Unfortunately, not playing. That alone is not playing. Okay, leave it. Now, this is 4 months after NSR, and you can see that the right vocal cord is well medialized. It is like a thyroplasty and much better result. I don't know why that previous didn't play. Anyway, that's not. So that's actually a very good option to do this surgery. Another patient, this was a patient of syringomyelia, has got a very bad voice. Wait, is getting stuck. I don't know. This is all after surgery. I don't know why that. Okay. This side is not playing. Is it something related to? See, this is played. I don't know why that. What happened?
From the main file,
Yeah, I can play that. How to go that? How to go for the folder? This one. Yeah. So I can show that case. No. Okay, leave it, then we'll play the other thing. Okay, you play. Now, suppose there only one vocal cord, one muscle is gone. Say like this was a case of, this was a singer who had a, where is my, it is going there. Here you can see that left vocal cord, even though it is moving, even though it is moving, the anterior tooth there is a phonatory gap. So here what you do is known as a neurotization or highly selective reinnervation. What you do is you do cut a thyroplasty window, take the ansa cervicalis and connect to the muscle. And this is the result after 4 months. You can see that. She couldn't sing at all. Her voice was so bad. She was a professional singer and was off stage for 2 years. That's okay. See that this is what the reinnervation does. No thyroplasty can do and then make that. Because you are actually giving tone to the muscle, which none of the procedures, none of the static procedures will actually make. So this is very different. You are actually making the thyroid node much stronger. So when do you do dynamic procedures in unilateral vocal cord palsy? Actually, you can do in every case, except these 3 contraindications. As of now, above the age of 70, we won't do that because the nerve growth may not be growth. Chronic uncontrolled diabetes is a contraindication because the reinnervation will be bad. And history of bilateral neck dissection, I told her, because head and neck surgeons are not that respectful to the ansa cervicalis. They will just take away that, right? So if they have done a bilateral neck dissection, then you may struggle to get an ansa cervicalis. So that's why it's important. Static procedures. So But if you are not doing, there is no harm in, you can always do the static procedures. So there are 3 static procedures. We have seen Manju talking about the anterior adductor, middle adductor, posterior adductor. If it is an anterior adductor, that means the phonatory gap is in the anterior 2/3. You will get a there is something very unusual about it. So this is the medialization thyroplasty. You all know that, and most probably this will play. Here, what is that? That's only on this side will play. I don't understand what is happening. So this is a medialization thyroplasty. So when you do the medialization thyroplasty, you can actually, this everybody is familiar, so I am not going to talk much about. So you can see that there was a right vocal cord palsy, thyroplasty was done, and actually you could close the gap. That's a good surgery. I am not telling that you should actually totally leave thyroplasty, nothing like that. But what you should understand that renervation is coming back coming in a very, very big way. Suppose LCA is gone, means lateral cricoid node is on, that means there will be a phonatory gap at the vocal process level. That will be a big gap. I think it has got some problem with the left side. I don't understand what exactly is. So you do the arytenoid rotation and then you get the closure. You can see that from the, even though it is a still picture, you can see there is a big phonatory gap at the vocal process level. Arytenoid is distorted. And arytenoid rotation is a terrific surgery that I will always admit. For this surgery, that surgery, you should actually go to Ishiki, because that's a very, very difficult surgery. How he conceived that concept in a local anesthesia in an area where there is jugular vein, carotid, pyriform fossa, he did that in a local anesthesia is unbelievable. And finally, very rarely you may get an interarytenoid paralysis like that, where the gap is too big. Again, Manju showed that this part won't come, body won't come here. It may not play, but yeah, left side, it has gone, I think, very rightist attitude. And then you do the adduction arytenoidopexy, where you open up the cricoarytenoid joint and fix. You can see that I am opening up the cricoarytenoid joint and fixing the cricoarytenoid more medially. You get what is this? Only so on that side you get the totally, see that this was far away, the body was far away. I think at the end of the lecture I will just show. So static procedures in established cases of UVFP, what are the contraindications? Obviously you can't do in an irradiated larynx. When you do a thyroplasty irradiated larynx, you cut the cartilage, chances are that more than good result, you will get bad result, because patient will develop perichondritis instead of having good voice. Earlier he had only bad voice, now he'll have swallowing problem also. So don't do that surgery in an irradiated larynx. That is very, very dangerous. So static procedures are in established case of UVP, contraindication irradiated larynx. Children is a relative contraindication. So what is now? What is the current concept? In established case of unilateral vocal fold palsy, management protocol, lots of overlapping happen. But what is evolving trend is that right now, this is what we do. I know that in India there are not many centers who do regularly. We are the people who do actually maximum. So first choice is now dynamic procedure. So if I get a unilateral vocal cord palsy, I don't actually go for thyroplasty now. I actually will do a dynamic procedure like non-selective reinnervation or highly selective reinnervation, if not contraindicated. So the two major contraindications are above the age of 70, I won't do a reinnervation. And if it is chronic uncontrolled diabetes, I won't do that. So what will happen? Static procedures like medialization laryngoplasty, that is thyroplasty, arytenoid rotation, and adduction arytenoidopexy, they are indicated when dynamic procedures are contraindicated. We already seen that. Diabetic patient above 70, and as a salvage procedure, when it fails, you have seen that the select reinnervation procedure has got a success rate of 90 to 95%. So there may be failure, like we also have got 1 or 2 cases where the tone came back but the bulk was not there. In that case, you will actually do the static procedures like thyroplasty and arytenoid. This is what is going to happen. This is what I believe. Right now, all over the world, there are people who do static procedure, there are people who do reinnervation procedure. But I think over the last few years, reinnervation is getting stronger and stronger. So this is our team. I think you can see this person there, right? And of course, Manju is the staff. So we have formed a Dr. Jaykumar's laryngology group. So that means that Raghavi is very much part of our team. So whenever she needs, she is very well trained. If she needs a support, either myself or Manju will be there to support her to do a surgery. Right. Thank you.
That has always been my strength to take up even difficult procedures, so that I know sir is backing me even during procedures. There are video calls that I make to sir, so that to ask doubts and everything, and to Manju madam, of course. So the floor is open for any questions.
Sir, in your postgraduate, you used to read about Tucker, who is doing a nerve muscle derivation.
Yeah, I think because of the time constraint only, I didn't put the name of Tucker also along with Crumley and Sean Paul Mary. Actually, that is probably easier. What Tucker did is that instead of taking nerve directly to the muscle, he took nerve with a small part of muscle, the strap muscle, and that is easier to suture. If there is a muscle on the end of the nerve, it is easy to suture to the laryngeal muscle. So occasionally we do that.
How do you suture, sir? Nerve to the muscle?
You cut a thyroplasty window, right? You take out, in thyroplasty you keep the internal perichondrium intact. In renervation you remove it so that you expose the thyroarynoid muscle, and you can see the longitudinal fiber. You open up with a artery forceps, then take a 7-0 prolin, take 2 sutures and bury it into it. So it's more of a microvascular training also is required. So to do that, what you need is essentially a good head and neck surgery background. An ENT surgeon who should be familiar with neck surgery and some microsurgical skills.
What material do you use, sir?
For what? 7-0 prolin. You can also use PDX. Yes, Thiru.
Yeah, thanks for the enlightening lecture as usual. Yes, sir. Do you do reinnervation from bilateral organ sir?
Yeah, that is entirely a different topic. That is known as a selective reinnervation. This is non-selective, highly selective. Selective reinnervation, because in unilateral vocal cord policy, you are not bothered about abduction. What you need is the paralyzed cord need to be adducted so that the normal vocal cord can come and hit normally. In bilateral vocal cord palsy, voice is not a priority, the airway is the priority. So all the static procedures like Kashima's chordotomy or all these things are actually expanding the glottis at the expense of the voice. So here comes the operation of selective reinnervation. This is far more difficult surgery and the results are not as great. So the quoted result is around 70% for the master, means Sean Paul Mary. I have done till now 8. So my success rate is around 50%. I think I have decannulated everybody, but that doesn't mean that the vocal cords are moving. So here what you do is, you take a nerve which fire during abduction and connect it to the posterior cricoid. The only major nerve there is phrenic. So you take the phrenic and take a cable graft and connect to the posterior cricoid node. And you take another cable graft and give adductor from the answer. That is what you do. So it is a much more, this surgery will take only 2 hours. Other will take around 6 to 7 hours, and you are actually totally denervating the larynx first. So for 2 weeks, patient won't be swallowing anything, will be on the Ryle's tube. But invariably, you will be able to take out the tracheostomy in 2 weeks' time because you have denervated the larynx. So the vocal cord will be in an abducted position, right? Children, my results are actually better with children. I think they do much better. But this is not as tremendous a surgery as in non-selective. But I think with more experience, I may get more result.
Yeah, because that should be the future, because in children, you do many surgeries for bilateral.
Actually, our 2 best results are one for a 4-year-old child who had a palsy from the birth, and another a teenager who was 16-year-old.
Maybe then you have to do for one of my patients. Yeah. I've tried everything. I tried Kachima, I tried English procedure. After English procedure, the child was all right for 6 months.
But then it comes back.
Then it came back. So I think maybe you have to try reinnervation. That is the only option left for the child.
And of course, there is one more option that might come, the PCA pacemaker. Posterior cricoid node pacemaker is an option. That also is on the verge of a breakthrough. It might come. So these 2 options.
Thank you, sir.
Thank you. Ah.
KKR.
Thank you, sir.
Now we go for the last session, that is by Dr. Sanjay. Sanjay sir is, Jayakumar sir is very early fellow. He shifted his career from being an ENT surgeon to a laryngologist at the age of 45, and he's now
Don't reveal his age.
okay, at the age of 45 he shifted, sir, so now you can guess. So, he is right now practicing in his clinic in Bangalore and in Nimhans as well, and he has a lot of things to share about the brain changes in associated with laryngology. So here he is going to be talking about the brain changes in UVCP. So one moment. Yes, sir. Yes. 1 minute. I will start. You just start. 1 minute, sir. I'll start. Just 1 minute, sir. This is a record. Sir, I'll just start this is a recorded talk, but sir will be available online for this thing.
Works in unilateral occult form.
Loudness. 1 minute.
Basically, I think many of you.
Screen share இங்கே பிரசன்ட் ஜூம்ல தான் இங்கேயும் வரல பிரசன்டேஷன் ஸ்டார்ட் பண்ணுமா
மைக் வேணும் அவங்க யாரும் பேசலாம் ஒரு மட்டும் ப்ளே பண்ணுங்க
Is it clear? I can't.
Yes, sir. With mic on. Sir, I can see
Hello?
you and hear you. We can see you and hear
Okay.
you.
So I'll start.
Yes, sir. Yes, sir. Please.
Okay. Thank you.
Yes.
So I thank Raghavi for inviting me and this opportunity to speak here. First of all, it's a pity that I'm not able to join you out there. I wish her all the best. Congratulate her in her new clinic. So I'm going to speak about brain networks in unilateral local fold paralysis. So I think many of you must be wondering as to why this talk. Already they have discussed the presentation and conservative management and surgical management. The importance is basically we know that the nervous system has got a peripheral nervous system and a central nervous system. So it would be very unfair to imagine that lesions of the peripheral nervous system do not affect the central nervous system, and vice versa, the central nervous system status has no effect on the recovery of the peripheral nervous system. Such relationship is quite obvious in other peripheral organs, but in vocal fold it has not been investigated because in this earlier other organs the animal models were used, and vocal phonation is a very skilled vocal performance in which animal models will not help us much. But recently, once functional brain imaging has started, this has helped us to assess the neural networks and working of the central nervous system, and new data has come into play. I would like to share a few studies to prove my point. So this is basically a study, a paper which came out. They took a normal patient, did an MRI and a functional MRI, saw the networks. After that, injected xylocaine and paralyzed the recurrent laryngeal nerve, did an endoscopy, confirmed that the patient had unilateral vocal fold paralysis, then did an MRI, and again waited for a few hours, couple of hours. And then afterwards did an endoscopy, confirmed that the vocal fold recovered because it was only induced paralysis, again did a functional MRI. So what was surprising was that after the vocal fold recovered, the functional MRI was not similar to the one pre-injection. So even though the vocal fold recovered, but the network changes in the brain didn't revert back to normal. So with just 1 hour of unilateral vocal fold paralysis, there was some changes in the brain or some sort of reorganization in the brain, what we call neuroplasticity. If for 1 hour this is there, imagine for a unilateral vocal fold paralysis of 6 months, 1 year, or a few years duration, what would happen? Then there was another study which came in which in this patient they did functional MRI in patients who had undergone a theroplasty type 1, 3 months, and they had another control group, and in this also they were able to say even though objectively the voices were good, but the network or the brain was not similar to the control. There were a lot of changes, and one highlight was what changes is seen in anxiety patients was also seen in these networks of these patients. So the paper suggested that in future treatments have to take into consideration the status of the networks if we want alignment with the judgment between the patients and the clinicians. This is another interesting study which came out recently from Europe, in which they did a functional MRI of 3 patients with unilateral vocal fold paralysis and a control patient. Patient 1, there was no recovery. Over 1 year, they did 4 MRIs, followed up the patient. Patient 2, there was spontaneous recovery. Patient 3, recovery after injection laryngoplasty. So the patient 1 obviously no recovery, so there was lot of difference between control and his a functional MRI. Patient 2 who recovered was very much similar to the control but not similar. There were still some changes. Whereas patient 3 MRI was a lot different than the control and even the patient 2. So this highlighted the point that even though 2 patients of vocal fold paralysis recovered after from unilateral vocal fold paralysis, the changes in the networks are very much different. So each person has got, or even though there is a recovery, what process or what cycle or pathway the neural networks take is a lot different. So this has renewed interest whether is there any way to tackle unilateral vocal fold paralysis by tackling the neural network. Before that, we have to understand how the neural system works in types of phonation. There are 3 levels. The lowest level is the medulla oblongata midbrain. Second level is the subcortical, and the third level is the cerebral cortex. All these levels contribute for a normal phonation, and feedback from the peripheral organs is very important for this. This is where is the link between the peripheral nervous system and the central nervous system. So this is a small chart I made. Once an individual decides to talk, there is a software in the brain that is activated, and you can see motor commands are initiated according to the software to the muscles to contract. Simultaneously, information from the motor system is relayed to the sensory system that if this muscle contraction is executed, what will be the sensory and rewarding consequences. Those, and when the muscle contracts, the real sensory and rewarding consequences are picked up by the sensory system and given to the sensory cortex. The sensory cortex will compare the real feedback from the expected feedback. If both are same, nothing happens, no corrective measures. If there is a difference, then the sensory cortex gives adaptive or corrective orders to the muscle contraction to rectify the muscle contraction. And it also updates the software. So you can see it is a constant dynamic and which involves both peripheral and central nervous system. So to summarize, sensory feedback is very important for monitoring the vocal output to make sure the actual output matches the intended output. But we have to understand the consequences are 2. One is sensory, one is rewarding. Sensory, in phonation we have auditory and somatosensory, which is analyzed in the cerebellum. Now you have singers who sing. This causes them joy and it causes dopamine release. Even I am giving this talk, there is a joy, I am happy. This also causes dopamine release. So there is a pathway for rewarding consequences which is analyzed in the basal ganglia. These are the various pathways. Now if I apply this to a patient with vocal fold paralysis, what will happen is if there is vocal fold paralysis, there is a gap. So obviously because there is a gap, the sensory feedback is altered and it is altered permanently. So it keeps giving rectification commands, but because of the paralysis, the gap will not reduce. So after a time, if a system is picking up continuously errors, what will happen? It will get overwhelmed, it will crash, it will stop working. So when you have in the loop one part of a system not working, the whole system gets impaired. This in turn will lead to impaired motor commands. I hope you were able to understand. So now studies have shown us that if there is a long-term mismatch between the sensory system and the motor system, this leads to changes in the networks of the brain. So, or this is associated. And there are various other studies, one more I have quoted, even in spasmodic dysphonia, that all these changes takes place in the networks of the brain. So this is, we are at present doing a study, we are doing functional MRI with old images. Then we have, through artificial intelligence, we have a software which we do to analyze these tracks and we assess them. So what has happened, the action has moved from the larynx to the brain. Because now in these patients, if you have problems in the networks, unless you change or make some rectification there, the patient might not be 100% cured. So neuromodulation techniques have started where they can stimulate or modify the brain. There is one delayed and altered auditory feedback which I am personally using. This is called Tomatis auditory therapy. Here, this is a therapy which was used to treat auditory processing impairments in children with autism. Technique. It has a passive phase and an active phase, where in passive phase a person listens to the music. In active phase he talks into a device. The device modifies the voice and gives it to the headphones, and he hears in headphones both bone conduction and air conduction. So I did a study on patients with muscle tension dysphonia who had not responded to voice therapy. We had very good results. We assumed that those who didn't respond to voice therapy had auditory processing or network changes, and we had a significant improvement in these patients. I have presented this in the Fall Voice Conference in San Francisco and the European Conference in Antalya. So I thought, why not use this also for vocal fold paralysis? Anyway, it is only case reports. I do not have a study because we have only started using it recently. I would like to share one patient voice details. This is a 45-year-old lady on whom we did non-selective laryngeal reinnovation. She had vocal fold paralysis, unilateral, 6 years duration. This is her voice. I hope you are able to hear the voice. It's very light. It's not a recording problem, but it is very, very light. Is the voice heard? I hope. I'm not sure. And then after 1 year, this was the voice. It improved. But it was not fully well. She felt that it could be nice. I also felt we can have a little better voice. So then I thought, why not use this technique? So this is, we used it, and this is after 18 months. These take the shape of a long round arch with its part high above and its two ends apparently beyond the horizon. There is, according to legend, a boiling point of gold at one end. People look, but no one ever finds it is looking for a bottom gold. So anyway, I can't say that it was only because of this, because non-selective laryngeal reinnovations are known to heal slowly. But nevertheless, I mean, we have to do a proper study is the thing. This is very early days. But what I would like to impress on you is the neural networks is one path which we need to address in these patients. And maybe the technique which I said is one of the things. We have to evolve techniques. And it might be a combination of peripheral and central, or if we are able to modulate, we can see who are the patients by modifying networks. We can see that in those patients, the vocal fold recover without any surgery. There is a role for that. But it is early days, I accept it. We still have a long way to go. So this is only to impress on you about this new pathway. Thank you.
Thank you very much, sir. Thank you very much, sir. Any questions? Any questions? Sir.
So if there's any questions, anything?
Audio poda. Audio poda. Can you hear me, sir? Can you hear me, sir?
Yeah. Now I can hear you. Yeah.
I don't think there are any questions now, sir. So we'll thank you so much for coming online and presenting, sir. Thank you very much.
Thank you very much. All the best.
Thank you, sir. Yeah, thank you, sir. Jayakumar sir just left for the flight. He just left.
No problem.
Yeah. Pa Jayakumar sir call pandra. So, thank you so much. This is my first CME and thank you all for attending. I have to tell special thanks to my professors who have come here and people who have spoken and my friends, all my friends who have actually helped to arrange all this, and especially your interest in laryngology which has brought you all here. I hope to do it better and at a larger scale for the next time. Thank you to the AV team, thank you to Prem and Pentax and for all the help they've done with the scope and the interiors and everything. So thank you very much. Yeah.